Welcome, welcome, welcome. I am so glad you're here. You are in the right place. As I often say, most people don't even know it's possible. Truly, most people don't even know it's possible to heal from chronic pain and chronic symptoms using emotional and psychological modalities, but you know it is. You know that it is, and that is what we are here to talk about today. Okay, so season 6, episode 2, we are settling into a new season. And as we are doing so, I want to reread my promise to the audience so we can resettle into that. All right. My promise to the audience: I will share clear and correct information about healing chronic pain from my personal experience and my professional knowledge so that you have the education you need to heal. And even more importantly, to provide you with the company of someone else walking this path so that you don't have to do it alone. Okay. That's so important, right? No one wants you doing this alone. Okay. No one wants you doing this alone, and you don't have to. You do not have to do this alone. All right. Today we are talking about the question: is neuroplastic healing backed by science? Okay. I will say yes. Yes, it is. And that's the whole episode, folks. All right. Talk to you next week. No. No, 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 no. If you like a short and sweet, you can. And if you believe me, that's great. You can stop the episode right there because you have enough information. Is neuroplastic healing backed by science? Yes. Full stop, done, period. For those of you who are like me and have a lot of doubts and need a lot of information, or those of you who are like me and just like to hang out and chat and listen and make it long form, great. Great. Because that's the plan for today. All right. So I'm going to end this episode on I have an interesting update to on something that I mentioned very tangentially in last week's episodes. I've got some tea for you, which is gay for gossip if you don't speak gay. But first, before we get to that, let's do the core of this theme here today, and we are going to look at many studies. I have earmarked 12 different studies for us to go through, and I would say I only actually earmarked one of them. The person who earmarked 11 of these, I want to give full credit to Nita Tansinson, who is a physical therapist. She was on this podcast earlier last season. Check that one out. It's titled "A Physical Therapist Who Can Help You" by Nita Tansinson. And that episode, that'll be linked in the show notes. It's a great conversation. Nita's awesome. A friend of mine from we met at the conference in Boulder, the ATNS conference last year. You can reach out to her. I mean, if you want a physical therapist who does this stuff, or you want to talk to a physical therapist who does this stuff, she is totally available. She's on Instagram at Nita Cares, NIDACARES. That's right down there as well in the show notes. And her email is down there as well, nita.paincoach@gmail.com. Okay. The studies. Let's start. Number 1, we're asking the question: is neuroplastic healing backed by science? All right. You already know the answer is yes, but we're going to settle in and we're going to prove it. Okay? We're going to prove that the answer is yes. We're going to get some actual information. Okay, and as we're getting into this one, I just am going to warn you in my notes for today, I've got all the studies. And I've also got I've got I'm a little heated about this one, okay? Like, this one gets me a little wound up, a little aggressive, to be honest. So, like, if you're not here for that energy, that's cool. You can back out. But if you're cool getting a little into, like, fuck everyone and like people are so dumb. That's how I'm feeling about this one. And I want to say that anger, like I'm someone who's been through a lot of medical trauma, and you probably are too. Okay, like that's probably both of us. So like, yeah, I want to validate myself that like if I'm angry, that's cool. If you're angry, that's cool. Um, so yeah, like I'm saying, if you're cool with a dose of that energy today, listen on. Okay, number one, the Boulder back pain study. You all knew it was coming. It's the most cited study in this field since it came out. The Boulder back pain study was published in JAMA Psychiatry in 2021. The authors on that are Yoni Ashar, Alan Gordon, and Howard Schubiner. Okay, from the study. Question: can a psychological treatment based on the reappraisal of primary chronic back pain as due to non dangerous central nervous system processes provide substantial and durable pain relief? Great question. That is a very fancy, heady scientific way of saying, do neuroplastic recovery therapies work? Or, does TMS therapy work? Or do emotional and psychological modalities really heal chronic pain? This one, honestly, that's I would say, do psychological modalities really heal chronic pain? Because they didn't test the emotional stuff as part of the PRT study that was this psychological side. We all know you got to do both. If you want to heal, you really got to do both. But well, some people maybe only need one, but most people need both. All right. Findings of the Boulder back pain study. In this randomized clinical trial, 33 of 50 participants, that's 66%, randomized to 4 weeks of pain reprocessing therapy, were pain-free or nearly pain-free at post-treatment. That's a really good result, right? So does this work? Yeah, that works pretty well. I would say that is pretty good. And 4 weeks is nothing. I'm like, how did they get such good results? I when I found this, I was not pain-free or nearly pain-free in 4 weeks. My God. I would not have been one of the 66%. That said, this is the way, and this has been the solution for me, and it is the solution. It just is the solution for, I mean, anyone who has TMS or a neuroplastic condition. This is it. This is the way forward. But okay, 66% were pain-free or nearly pain-free at post-treatment. Okay, there were 20% of people randomized to a placebo group, and there were 10% of the participants were randomized to usual care, just, told to continue whatever they were doing for their back pain. Those people did not improve significantly. With the treatment group, the gains were largely maintained at a 1-year follow-up. Treatment effects on pain were mediated by reduced beliefs that pain indicates tissue damage, so important. And longitudinal, oh my God, there's about to be a lot of big words in this one. I'm like, can I do them all? Longitudinal, oh my God, it's an fMRI, is what they're saying. What is it? Longitudinal functional magnetic resonance imaging. I'm like, whoa, the dyslexia is really tripping me up. fMRI imaging showed reduced prefrontal responses to evoked back pain and increased resting prefrontal somatosensory connectivity in patients randomized to the treatment group relative to those randomized to placebo and usual care. What does that really mean? It means their brains literally changed. fMRIs showed their brains literally changed. Reduced prefrontal responses to back pain. Not only are they just like sort of thinking differently, their brains are actually responding physically differently. It changes the brain. Even when the pain is not being evoked, it changes the brain. How cool is that? And let me just say, that's what you're doing right now. by listening to this podcast and by doing this work, you're doing that right now. You're changing your brain. Okay? How cool is that? You're changing your brain. Okay, so meaning of the boulder back pain study, what can we conclude? Psychological treatment focused on changing beliefs about the causes and threat value of primary chronic back pain may provide substantial and durable pain relief. It's funny, these are so like they're so like conservative in the way that they do this. It may provide substantial and durable pain relief. Yeah, it may. All right, it may. I think that's understating it, but they're being very careful. Okay. So important things, the brain mechanism, like I said, fMRI scans confirm that patients who completed PRT experienced reduced activity in brain regions associated with threat and pain perception. You are doing that now. And an important part of this, the false alarm concept. Pain reprocessing therapy. The therapy operates on the premise that chronic pain is often a learned false alarm from the nervous system rather than ongoing physical tissue damage. We all know that sometimes pain is a false alarm. It's created psychologically in your brain, and it then obviously manifests in your body, and it does not need to be there. Sometimes, though, pain is a real alarm. Pain and symptoms are real alarms. And I mean, so sometimes you're in pain because there's something really physically going on that is dangerous. Your hand is on a hot stove. You've been punched in the face. I don't know, you maybe have some physical damage to your body at the site of the pain. That is possible. And so that we certainly can't say that never happens, because it does. That definitely does. Not everything in this world is TMS. Not everything in this world is neuroplastic. But a lot of things are. Okay, a lot of things are. And so sometimes the pain is a real alarm in that there's something really physically wrong with your body. Can't ignore that. And sometimes the pain is a real alarm in that there's some deep emotional conflict going on. There's some repressed emotion that's trying to rise, but your system is very, very afraid of it and threatened by it. There's parts of yourself that you are ignoring, and as they rise, you're very threatened, and there's so much internal conflict. Sometimes the pain is a real alarm. You may be feeling the pain in your back, and your back is totally fine. The real problem is that you are so out of alignment with your true self, or you are so not feeling your real emotions and you're repressing your emotions, or you have a lot of conflict with the people in your life, but you're not allowing yourself to feel it and acknowledge it. All that stuff may be happening too. So that leads us into number 2. Study number 2. All right, number 1 is pain reprocessing therapy. Study number 2. Emotional awareness and expression therapy study. All right, emotional awareness and expression therapy for chronic pain. Rationale, principles and techniques, evidence, and critical review. These are so wordy. The way they write is like, oh my God. All right, this was published in 2019 by Mark Lumley and Howard Schubiner, who were the two trainers when I was trained in emotional awareness and expression therapy. I was trained by the two of them, straight from the source. How cool is that? All right, the EAET study. Purpose of the review. Patients with chronic pain, especially primary or centralized pain, have elevated rates of psychosocial trauma and intrapersonal or intrapsychic conflict. Check, check. That's what we were just talking about. To address these risk factors and potentially reduce pain, the authors developed emotional awareness and expression therapy, or EAET. All right, recent findings. 4 initial trials between 2006 and 2011 demonstrated efficacy of earlier versions of EAET. 4 recent randomized controlled trials, that's top of the line, a randomized controlled trial, 4 recent randomized controlled trials of different EAET durations, 1 to 8 sessions, and formats, some individual, some group, in patients with fibromyalgia, irritable bowel syndrome, pelvic pain, or medically unexplained symptoms. So, all different TMS presentations, all different neuroplastic presentations. 4 recent studies support the earlier findings. EAET, this is emotional awareness and expression, reliably reduces pain. The largest conducted trial found superiority of EAET over cognitive behavioral therapy for fibromyalgia. Obviously, no surprise to you, what helps people more? CBT for chronic pain or EAET for chronic pain? Obviously, EAET helps more. All right, so summary. EAET merits inclusion as a treatment option for primary pain conditions, and it may be the preferred treatment for some patients. Yes, indeed. Research is, and then again, they've these very, very, very conservative, findings. Research is needed on EAET with other pain conditions and samples. Oh, this I thought was funny. And including additional ways to motivate and help patients engage in successful emotional processing. Yeah. Well, yeah. This work is hard, okay? Nobody does nobody does emotional awareness and expression to you. You do that yourself, all right? People can help you. I help my clients with this stuff every day. This is literally my job. So people can help you, and having help is invaluable. Truly having help, I do believe, is invaluable. But nobody does it for you. You do it yourself. And so I do think it's funny. Additional ways to motivate and help patients engage in successful emotional processing. I'm sure what they mean there is that, like, a lot of their patients could have done better had they successfully engaged in emotional processing. I can't force people to do it. Okay. Looks like Howard Schubiner and Mark Lumley can't either. But here's the thing. I would not say your job is to force yourself to do it, but you can allow it. You have the power to allow your emotions to rise and to allow them to be processed. Okay. And you have the power to contact a therapist like me or somebody else in this field to help you with that process, because that will speed it along for you. All right. Is what are we asking? Is neuroplastic healing backed by science? Study number 1, PRT, check. Yes, it sure is. Study number 2, EAET, check. Yes, it sure is backed by science. It sure is. I want to pause with this one for a little bit, EAET. I want to pause and just drill down. Cognitive behavioral therapy. I would say that's like the standard option for psychotherapy for chronic pain. Is cognitive behavioral therapy for chronic pain supported by science? Sure, yes. CBT has some positive effects, but EAET and PRT, which we are profiling today, get much better results. And this study right here shows that EAET is superior to CBT, which, you know, like I said, because the scientific community is very, very, very conservative in their approach in this way, they're not saying, like, if EAET is superior to CBT for chronic pain related to fibromyalgia, then that generalizes to other neuroplastic pain conditions. They would never say that, because that's way too far of a leap. They're saying, like, further research is needed to test this treatment with other primary pain conditions. Let me tell you, folks, this ship moves real slow. Further research, that may take decades, folks. All right. Decades. Do you have decades? No, you do not. This is your life. Today, tomorrow, every day that goes by, this is your life. You have the opportunity to live your life better, healthier, less pain, less symptomatic. We're not waiting around. We are not waiting around to be like, oh, okay. So my specific issue is actually what is an issue? Shoulder pain, plantar fasciitis. I am not going to engage in EAET or CBT until I see a study where this helps people with shoulder pain or plantar fasciitis. Don't be that person. Okay. You do the study on yourself. All right. That's my suggestion to you. You do the study yourself, because you might be waiting decades to get an answer that I'm pretty sure we all know what it's going to be, which is that EAET is more helpful than cognitive behavioral therapy for all the neuroplastic pain. I'm just going to go out on, I wouldn't even call this a limb. I'm gonna go out on have I done a randomized controlled trial over this? No. But am I confident that emotional awareness and expression helps with all forms of chronic pain? Yes, I am fully confident in that. You may take that in if you want to live a better life. We're not waiting around. All right. We're not waiting around. We know the neuroplastic TMS symptoms all come from the same source. They come from the brain. So the same treatment, the psychological work, which is PRT, the emotional work, which is EAET, that works to resolve all forms of TMS and chronic pain. Don't go to CBT for chronic pain, folks. You know too much. You're listening to this podcast. Don't do it. Do not do it. What CBT for chronic pain is skills to cope with and manage life in your limited body. Okay. Do some people with some conditions need to learn how to cope and manage in a limited body? Yes. I mean, not everything is TMS. Not everything is neuroplastic. Yeah, some people, if it's not TMS or not neuroplastic, yeah, there are, I mean, I don't know. There's so many different things. Say you have chronic. I'm not even going to throw things out there because I am not a doctor. I don't know what is what, but I know that there are conditions like I don't know, chronic liver disease, kidney disease, or those things. If there's organ damage or there, not everything is TMS. All right, not everything is TMS. Some of these conditions need to be learned to be need to be learned, you need to manage them, learn to live with it. If you're here and you're dealing with TMS, you're not in that category. Okay? Your symptoms are not in that category. Is it necessary for you to figure out how to cope and live with it? No, it's not, because what's going to be way better is to figure out how to reduce and eventually even eliminate the symptoms. That's going to be so much better. Go this route. Go this route. Okay. So, little story about this, which I actually thought was very interesting. The reason I'm like harping on this is because I'm like, this is so important. Don't limit yourself and you don't have to. Don't do that to yourself. Um, I was in a consult group for chronic pain therapists a while back, which was awesome. And one of the therapists in the group was brand new to the TMS paradigm. So he was brand new to PRT and EAET, which, I mean, like, those are relatively new treatments, so we're all kind of new to them. But this uh, therapist, he was brand new to like this whole world of thinking, and he'd been a practicing therapist for a while, and his modality, interestingly, was CBT for managing, not healing, but managing chronic pain. So he found out about PRT and EAET and the whole TMS neuroplastic recovery therapy world and was like, damn, this is awesome. This would definitely be helpful to a lot of my patients and like take a lot of people to like a next level, obviously. So, he was like, I want to learn more. Awesome. He was open. Awesome. You are too. Awesome. So while I was in this group with this other therapist, and there were other people in there too. The other people, the TMS and neuroplastic people, were lamenting like it can be hard to find clients who really want to do this work or who really understand this work or who are really like looking for this work because not a lot of people know about it. Like, awareness about this stuff is not where it should be, et cetera, et cetera. That kind of conversation. And, the various therapists and providers were like, in this group, we were like, I usually have a space or two open in my caseload. It's hard to maintain a consistently full practice with this niche specialty that so many people have not heard of or like kind of don't believe in or think is crazy, et cetera, that sort of thing. And this killed me. This therapist who worked with pain from the don't heal it, but manage it with old school style CBT frame, he was like, guys, my practice is always full with a wait list. I have doctors begging me to take their patients, and I can't handle the volume. Right. So the neuroplastic people were like, "OMG, what?" And, same, obviously same. I was like, "OMG, imagine a mainstream doctor referring a patient to my practice." That's literally laughable at this point. That's literally laughable. Oh, and it just the reason I'm talking about this is because I'm like, "Why? Why is that?" And I think there are nice ways to say it, and then there's also you can just say, "People are dumb." People are dumb. People have small minds, okay? And, same. People are scared and dumb. Same and same, okay? But this is an opportunity to think differently, okay? This is an opportunity to evolve your mindset, and that will evolve your life. People are dumb, but you don't have to be one of them, okay? And you can, I'm dumb in a lot of ways. I'm like trying to read through these studies and I'm like, I can't even pronounce these words. Yeah, I'm dumb too. Okay. Welcome. But I'm not dumb in this way. The studies are out. EAET and PRT are better. That's emotional work and psychological work. I mean, these are basically just ways to standardize emotional work and psychological work so that it can be tested. EAET and PRT, and so you can train other clinicians in these paradigms. Like I've been trained in both, and it's the same shit. It's the same kind of stuff that Dr. Sarno was doing many years ago. It's all slightly different versions of the same basic paradigm. It's the same stuff. But what I'm saying is the studies are out. The verdict is in. Emotional work and psychological work are better for chronic pain by far than CBT. Doctors in the medical system, A, don't know about these studies. B, these studies are new, and this wasn't part of their original training. So, it's hard to integrate new stuff sometimes. And C, doctors are human. Okay. I think that's honestly the most important part. Doctors are a little dumb. And I do not say that to disparage doctors, okay? Like I'm saying, I'm a little dumb too. I say this to normalize doctors. I'm going to boldly stick with the statement doctors are a little dumb. I'm not going to walk that back because this is a podcast about chronic pain. And this currently, you and I right now, we are in a dark ages moment in chronic pain treatment right now, okay? I know this audience. Many of us put doctors on a pedestal, okay? While it is imperative to take care of your health, yes, it sure is. And doctors are an indispensable resource. Without modern medicine, I'm sure I would be literally dead at age 2 from scarlet fever. This podcast would not exist. My life would not exist. Modern medicine is miraculous. It is indispensable. Go see doctors, please. I would never say don't do that. Go see doctors. And remember, take them off the pedestal, especially when it comes to chronic pain, okay? Chronic pain and chronic symptoms, most mainstream doctors, they don't know how to help you. Take them off the pedestal. Okay. People who do not think that chronic pain can be curable. We live in a world where people don't know that healing on this level is possible. That includes doctors. Most people don't even see it. Most people don't think it's people think it's too good to be true. People think it's crazy. We don't allow ourselves to get too excited because we're humans and we're scared to be wrong. We're small-minded. We're jaded. We're cynical. We're traumatized. Okay, trust yourself. Don't trust. I mean, trust people. You know what? You know what I know. You know what I mean. Trust people, but know that you can also trust yourself. You can also trust your body. You can trust yourself. All right. And let me just say that doctors don't want to get sued for doing something that seems strange or new. I wish doctors would get sued for offering surgery or CBT to TMS patients because, man, the courts would be clogged up for years if everyone with TMS who got the wrong treatment and had a bad outcome, if every provider was sued for damages, the courts would be clogged up for years. But I mean, honestly, I don't even wish that because, Everyone has made mistakes. Every professional has made mistakes in their practice. We don't know everything, Same. I used to know nothing about chronic pain. I mean, I will say in my defense, I was not treating chronic physical pain when I didn't know how to work with it. I will at least say that to my credit. But, for example, when I was a brand new therapist, I didn't understand much about trauma and trauma's central impact. And so I made some really dumb moves when I was a young therapist, like some really dumb oversights. Um, I've been there too. I have totally been there too. Now, I mean, many years into my practice and lots of training and society has evolved. The knowledge base has evolved in that time as well. Now, I think I do a good job working with trauma. I just think I do a good job working with chronic pain and symptoms. Um, but I will learn more and evolve more as time goes, Like, wow, wow. So, what I'm saying to round this part out, let's, raise a glass right here, right now. Here's to the medical field hearing and seeing and understanding this research because so many of us would already be healed from our pains and our symptoms by now if we'd been introduced to these concepts 5 years earlier, 10 years earlier. Say you started walking this path 5 years sooner, 10 years sooner, you'd already be out of pain and symptoms by now. And alas, you had to go through a lot more bullshit, maybe years or decades before you got here. And yeah, denial of the syndrome is part of the syndrome. That's a classic Dr. Sarno line. Um, the symptoms exist in part to protect us from difficult emotions. That happens at a societal level as well. You think most doctors are great with handling their patients' emotions? I do not think so. You think most doctors are great with handling their own emotions? I do not think so. A lot of therapists aren't great at handling their own emotions. Emotions are difficult. I'm not great with handling my emotions half the time because, it's hard. It is hard. So, okay, let's raise a glass. Here's to this antiquated CBT shit and, the doctors who refer their patients into these modalities. Here's to the patients who, like many of us, used to have such limited mindsets and such limited senses of their own potential. Here's to people who truly believe that they're unfixable, that they're unhelpable, and they just have to cope. Man. Here's to those people waking up to their true potential. And here's to neuroplastic recovery therapies being an option on the table for everyone who could benefit from them. Okay, that was a real deep dive into study number 2, and I'm just, off on a tangent. I wouldn't call this a tangent, this is central. Let me take that back, that's not a tangent. This is central to your understanding, and to mine. Okay, study number 3, the Brinjikji study. I think I'm saying that right, Brinjikji. Systematic literature review of imaging features of spinal degeneration in asymptomatic populations. This was first published in 2014. All right. So here we go. Abstract. Degenerative changes are commonly found in spine imaging, but often occur in pain-free individuals. Right. They sure do. They occur in pain-free individuals as well as those with back pain. We sought to estimate the prevalence by age of common degenerative spine conditions by performing a systematic review studying the prevalence of spine degeneration on imaging in asymptomatic individuals. Okay. So materials and methods. We performed a systematic review of articles reporting the prevalence of imaging findings, CT or MR imaging in asymptomatic individuals. All right. This is a study about normal abnormalities. That's what this is about. Results. 33 articles reporting imaging findings from 3,110 asymptomatic individuals, okay, met our study inclusion criteria. The prevalence of disc degeneration in asymptomatic individuals is I mean, it's a lot. It's not worth getting into all the numbers, like, it'll bore you. It's a lot. There is major disc degeneration in asymptomatic individuals. This means people without any kind of chronic pain, their spines are fucked up too, all right? Just a little bit. 37% of 20-year-old individuals have some disc degeneration. 96% of 80-year-old individuals have some disc degeneration. None of these people had pain. It's a normal aging process. None of these people had pain. Disc bulging prevalence, 30% of those 20 years of age had disc bulging. 84% of those 80 years of age had disc bulging. And I just want to say again, this is not like, and the young people had no pain, and the old people with the disc bulges had pain. All of these people have no pain. All of these people have no chronic pain. So, all that stuff, these are asymptomatic individuals. Conclusion: imaging findings of spine degeneration are present in high proportions of asymptomatic individuals, increasing with age. Many imaging-based degenerative features are likely part of normal aging and unassociated with pain. Okay, this study has been out since, oh my God, 2014. Okay? And doctors are not practicing using this information. They're practicing using outdated medical misinformation. Truly, in most cases, getting spinal surgery on your spine by a doctor is getting a treatment that is based on a paradigm that is based in medical misinformation and just not knowing. It's based in not knowing. This study is out now. People should know this. People should know this, and they don't. But here's the thing. Good thing you do. You do know this. Um, oh, isn't it nuts? How is this information out there and people think we're crazy, but then people are really willing to get a back surgery, really willing to get a back surgery. A family member of mine actually just got back surgery. Typical. Typical. Why does this happen? A, people don't know. B, people's mindsets are small. And C, remember, denial of the syndrome is part of the syndrome. On some level, it takes depth and courage to face your emotions. It really does. And on some level, it's actually easier to get surgery than it is to face your emotions. Even though, on another level, it's much easier to just face your emotions than to get cut open and all that. On some level, it's easier. On some level, it is easier. Okay, you don't need to be that person. Unless, say you get evaluated and you really do need to be that person. Okay, in most cases, you do not need to be that person. All right, that's study number 4. Study number 5, Blankstein et al. MRI hip findings in asymptomatic professional rugby players, ballet dancers, and age-matched controls. All right, the studies from 2019 looked at 11 pro rugby players, 10 pro dancers, and 10 medical students, all who had no pain or other hip symptoms. These are people whose hips are fine. They found labral tears in 90% of the rugby players who had no pain, 90% of the dancers who had no pain, and 80% of the medical students who had no pain. All right. They also found bone anatomy, like a femoral cam deformity. I think I'm saying that right. Um, Things that doctors attribute as the cause of hip pain regularly. They found that in 63% of the rugby players, in 80% of the dancers, and 60% of the medical students. All right. 40 to 60% range of these subjects had lost cartilage in their hip sockets. Some had lost cartilage in the femur, and some had signs of bone swelling. Some had labral cysts. None had hip pain. None. So if your doctor has blamed your hip pain on a labral tear, on the femoral cam deformity, which I've never heard of, but say they're saying that, lost cartilage, not necessarily. That does not have to cause pain. That does not have to cause pain. These Folks, what these are normal abnormalities. This study shows us scientifically that Dr. Sarno was right. Doctors blame structural changes for chronic pain in many of these situations, but these findings are actually normal abnormalities. Here's the evidence right here. Here's the evidence right here. All right, that's study number 5. Cruising along, study number 6. Zhang et al. Incidence of spontaneous reabsorption of lumbar disc herniation, a meta-analysis. This is from 2017. This is a meta-analysis published in Pain Physician. It found that that must be a publication, Pain Physician. It found that approximately 66% of lumbar disc herniations undergo spontaneous reabsorption, which is healing, without surgery within 6 months. So this study reviewed 11 cohort studies. It suggests that the body is capable of reabsorbing herniated disc material. This suggests that back pain that's persistent after 6 months is likely not due to bodily injury. The study also indicated that the mechanism seems to be the body's immune system recognizes the herniated material as foreign, which triggers an inflammatory response that breaks down and reabsorbs the disc material. And isn't that interesting? Wow. So if your doctor is blaming your back pain on a disc herniation, first of all, wrong. That's not true. And second, that herniation may very well go away on its own in 6 months. Isn't that nuts? All right, that's study number 6. Study number 7. Barreto et al. Bilateral magnetic resonance imaging findings in individuals with unilateral shoulder pain. All right, so this looked at 123 people with shoulder pain on one side. They took an MRI of both shoulders, the painful side and the side with no pain. Abnormal findings were highly prevalent in both shoulders, including labral tears in the shoulder, tendon issues, arthritis, partial rotator cuff tears, etc. The study concludes that most abnormal MRI findings were not different in frequency between the painful shoulder and the pain-free shoulder. Again, normal abnormalities. This stuff is out there, people. This is a study from 2019. How many doctors are doing shoulder surgeries still? How? How is this happening? Oh, right, because people are dumb. I feel like it's very like controversial. I feel like saying this is like controversial and I'm like pushing the envelope, but I'm like, I'm with you. I'm dumb too. Let's not be dumb in this way anymore, okay? Let's make an agreement with each other not to be dumb in this way anymore. We're over this. We can do better than this. We're smarter than this. All right. Study number 8. Bergman et al. This is asymptomatic tibial stress reactions, MRI detection and clinical follow-up in distance runners. Signs of a tibial stress reaction were found on MRI in 43% of the 21 asymptomatic college distant runners in the study. The presence of these changes was not found to be a predictor of future tibial stress reactions or stress fractures. Our findings underscore the importance of correlating MRI findings with clinical findings before making therapeutic decisions. Yeah, that's a very conservative way of saying it's not about the tibial stress. What is it? The changes, this tibial stress physical signs of tibial stress reaction. It's not about that. It's like you can't trust the MRIs, people. You can't trust the MRIs. And so a very conservative way of putting that is they want to underscore the importance of correlating MRI findings with clinical findings before making therapeutic decisions. What if they just said like in many cases you got to throw it out. MRI is super helpful in some cases. In many cases you got to throw it out. You just got to throw it out. It's not going to help you. All right, study number 9. Horga et al. This one is all about knees. This is what? The prevalence of abnormal findings in 230 knees of asymptomatic adults. Pain-free subjects Pain-free, pain-free, pain-free. Age 25 to 79, they found that 62% of these pain-free subjects had cartilage damage in their knees. 52% had bone marrow swelling. 48% had meniscus damage. 46% had, I don't even know how to say that, but they had some other issue. And 38% had ligament lesions. 33% had Baker's cysts. Around 25% had patellar bursitis, swelling, and changes of the foot pad. Just to reiterate, all 230 had no pain. Again, these are different versions of the same study. It's like, it's in the back, it's in the knee, it's in the shoulder. This, the same principle applies. These are normal abnormalities and they do not lead to pain. Okay. Study number 10, Webster et al. So this is a study, 2013. This one, yeah. All right, you ready for this? This highlights the shadow side of early diagnostic imaging. This is I'm going back to saying, like, in some cases you throw the MRI out because it's not going to help you. And this study actually shows scientifically that it can actually make it worse. All right. So this is early diagnostic imaging, specifically how early MRI scans for acute low back pain can lead to worse clinical outcomes. Not only that, but also higher costs. A phenomenon known as iatrogenic. I think I'm saying that right. Iatrogenic harm, which means physician-induced harm. So, okay, iatrogenic harm, worse outcomes. So this was a study of all like people who are out on work, like out on disability from work related, stuff. So worse outcomes. Workers who received an MRI within the first 30 days of an injury had significantly longer durations of disability compared to those who did not receive early imaging. Wow. So that's the nocebo effect right there, plain as day. We see it in science. Also, higher costs. Early MRI was associated with a massive increase in medical costs, even after adjusting for injury severity. The early MRI group, wow, spent approximately $12,000 to $14,000 more dollars per claim. Wow. Cascade of interventions, also early imaging acted as a gateway to more invasive and often unnecessary treatments down the line, including a higher likelihood of surgery and prolonged use of opioid medications. That study is, wow. That one I'm like shook. Webster et al. Wow. Iatrogenic consequences of early MRI, an early MRI might really mess you up. All right, that's study number 10. Study number 11, Zamorano et al. This is an interesting one. Pain sensitivity and tactile spatial acuity are altered in healthy musicians as in chronic pain patients. All right, so this research highlights that musicians, particularly violinists, exhibit increased pain sensitivity compared to non-musicians. Essentially, the more important hand, like the hand that's highly trained and used on the strings of the violin, that hand is more sensitive to pain experience. So what they say is this indicates that intense repetitive training alters somatosensory pathways, increasing the risk of chronic pain due to cortical reorganization. All right. Key findings on violinist hand sensitivity. Intensive training causes the brain to allocate more cells to the map of one hand in violinists in the brain. So sensitivity and pain, while violinists have higher tactile sensitivity, like finer, what they describe as finer 2-point discrimination, they have the higher tactile sensitivity in the one hand. They also show higher sensitivity to pressure and heat pain compared to non-musicians, which is interesting. Risk factors here, they say, are the extensive, repetitive, and highly skilled movements of classical musicians act as a risk factor for developing chronic pain as their brains are more sensitive to danger signals. Okay, interesting. So yeah, putting a ton of attention into a part of your body increases the risk of pain and sensitivity. Wow. All right. And there are more. Nita Tansinsen's list is long, but I'm going to cap it at 12. Number 12, Crum et al. This is from 2007. The placebo effect. In a study testing whether the relationship between exercise and health is moderated by one's mindset, 84 female room attendants working in 7 different hotels were measured on physiological health variables affected by exercise. Those in the informed condition were told that the work they do, which is cleaning hotel rooms and being on their feet all day, is good exercise and satisfies the Surgeon General's recommendations for an active lifestyle. Examples of how their work was exercise were provided. Subjects in the control group were not given this information. All right, so what they say is although actual behavior did not change, 4 weeks after the intervention, the informed group perceived themselves to be getting significantly more exercise than before. Compared with the control group, the informed group also showed a decrease in weight, a decrease in blood pressure, a decrease in body fat, decrease in waist to hip ratio, and decrease in body and BMI, body mass index. Isn't that nuts? That one really got me. These results support what it says is support the hypothesis that exercise affects health in part via the placebo effect. Isn't that wild? It's like, think great waist to hip ratio, get great waist to hip ratio. Which I think that is probably an overreach in generalizability, which is why scientific studies are very conservative the way they are. But isn't that fascinating? Isn't that fascinating? Okay, so there you have it, folks. There are 12 um, studies right there with compiled by Nita Tansinsen and with some analysis from yours truly. Okay, so is neuroplastic healing backed by science? It looks like it is, folks. It looks like it is. Whew. All right. And as we're winding down, I'm going to end with this an update on a little story about Ehlers-Danlos and POTS. Okay. So since today we're talking about the scientific proof for, like, is neuroplastic healing backed by science, I'm going to go back to this little story. All right. In last week's episode, which is a very fun interview with Jess Friedman, fellow psychotherapist in the mind body space in New York. You can listen to that one if you haven't. It's a good one. She and I were talking last week about the way so many psychotherapists don't understand the neuroplastic orientation towards chronic pain. Many professionals, many people just plain don't get TMS. They don't know about it. They just don't know, as we are discussing today. And so I told her I'm part of a few therapist listservs, and I get these emails. Like, I get many, many emails every day from literally. I'm just gonna open it up right now. Look, we go. I'm like in another tab. As every day it's like looking for a psych provider in network with United Healthcare for suicidal ideation, shame, and anxiety. Oh, this is cute. Looking for a headshot photographer. Love that. Looking for a female EMDR therapist in network with Blue Cross Blue Shield. No out of network, please. Looking for decolonial therapists. Love that. In network with Blue Cross Blue Shield. So I'm getting these emails all day, every day. An email went out on June 29th. So this was pretty recently. An email went out saying EDS, which refers to Ehlers-Danlos syndrome, and POTS, postural orthostatic tachycardia syndrome. I'm totally pulling that out. I didn't even look that up, but I think that's correct. POTS is TMS. It's a form of TMS. Well, I'm not going to get into it. It's like dizziness and etc. Heart rate stuff too, like wild heart rate variation, POTS. But okay. So the email went out. on June 29th, EDS and POTS experiences with pregnancy and parenting. So this got my attention because I'm like, oh, this is a neuroplastic situation. We're dealing with TMS here. Hi all. I'm reaching out on behalf of a client who is considering becoming pregnant and or parenting, but is lacking examples of people who have made this viable given these specific physical disabilities. If you have any resources for people sharing their experiences with this issue, online or support/therapy groups, I would really welcome that! Exclamation point. Client is speaking to her doctors, but if you're familiar with an NYC EDS/POTS competent OBGYN, that would be awesome too. Thank you. Warmly, therapist name. So I'm like, yeah, like this. I'm like, I see this email and I'm like, this client is one of us, right? Like this is a TMS patient right here. I'm like, I see you. So of course I think like, I don't know if I should respond to this because I can tell this therapist is in a totally different paradigm and like, what's the point? But then I was like, no, you know what? No, let me just plain respond without over explaining myself, without like apologizing for my explanation. Let me just drop some resources for this therapist because didn't I wish that some provider had dropped some resources for me about mind body healing like years before I actually stumbled upon it? I sure did. So I ended up writing a response that was, "Hi, therapist name. For sure!" Exclamation point. Here are two resources. Neither is specifically about pregnancy, but both are about using neuroplasticity to recover from EDS and POTS. Then there's Gigi Cockell in conversation with Dan Buglio, link to that video, and then Grace Secker in conversation with me, link to that podcast episode. And then I also wrote, I know Gigi, I know both Gigi and Grace, both have a lot of wisdom to share. Both are professional providers in the somatic healing space, and both are awesome. Smiley face. Wishing all the best for your client, Sean. Okay, sent. And then so I'm like, okay, that happened. Couple days pass. This was July 7th, so this was very recently. Um, another email comes out on this chain, and this time the therapist, like, ups the ante a little bit. This one is sent out to 3 different listservs all in one email, and here is the message from this therapist. Sending this out again because unfortunately I didn't get many responses relevant to the specific request. EDS trifecta specific resources. I will just say trifecta. I'm pretty sure that refers to like EDS is often present with POTS and mast cell activation syndrome. Like those are often, they go together and they're referred to as a trifecta. So I assume that's what this therapist is talking about. Um, you know how that is. Many TMS sufferers have many symptoms. We all know that in this community. But okay, back to the email. Specific, relevant to this specific request. EDS trifecta specific resources for pregnancy and parenting. These could be support groups, therapy groups, OBGYNs in NYC, OTs who can work with that trifecta and create accommodations for this disability during pregnancy and parenting. And then there's more. And so I was like, okay. I mean, this is clearly a therapist who does not understand TMS and neuroplastic recovery therapy is obviously fine. I didn't expect her to. But I'm also like, okay, you're looking for a therapist. Grace Secker is a therapist. You're looking for therapy groups. Grace Secker runs groups. And I know Grace does coaching and is available online. And even though she's located in, I believe, Colorado, she is able to do coaching with people, and her groups are able to, she works with people all over. She doesn't have restrictions. So I'm like, I'm giving you resources. I'm giving what you're asking for, but not exactly what you're asking for, which I understand. It's not exactly about pregnancy. I understand that. I'm not offering that. But this just annoyed me because I'm like, Jesus, like the I don't know. The negativity of the tone bothers me. The limited mindset bothers me. And here's the tea. Here's the real tea. As a therapist with a private practice, part of my job is to advertise my practice. So, potential clients know that I exist and they know what I do and they know how I can help. And this is so people can like A, find me, and B, so like the right people find me. Like in order to be a therapist, I need the business to generate revenue, and I need to have clients. Um, and I don't want to have clients who are, like acutely suffering from conditions I don't know much about or I can't like really help them with. Like, say, if I had a bunch of people reaching out with like rapid cycling bipolar disorders, or they're currently going through like postpartum depression, or like I want clients who have TMS, and they find me because that's what they have, and because that's what I can really help them with. So I have to put out some advertising so people know uh, people know what I can help them with. So I have my little marketing plan. I have my website. I network with other professionals. I have my podcast. Obviously, that's the best part. I have social media, which is not the best part, not really my thing, but you can follow me there at Mind Body Medicine for Chronic Pain. I'd love to have you there. Um, I'm on some therapist listings. I'm like on the pain reprocessing therapy listing, for example. I'm part of some listservs like this one I'm talking about now. And lately, I have been doing something a little new, which is dabbling in and learning about SEO. That is search engine optimization. If you've never heard of that before, I hadn't heard of it before I became a business owner, but I know a lot of people are familiar with that. I just hadn't heard of it. I'm not a tech person, so I don't like really dabble in that stuff, but I am dabbling in it now. So SEO is optimizing your website so that when someone Googles Sean Hershey, you pop up first. And then you can optimize your website in an attempt to get it to pop up in search results when someone searches like gay somatic therapist NYC or gay chronic pain therapist NYC. Now, I will say SeanHershey.com is doing pretty well in the Google search for gay chronic pain therapist NYC. You can try that out on your phone if you want. I hope it works for you. Um, I know if you Google gay chronic pain therapist NYC, um, and on my phone, I certainly show up. And not only in the search results, but in the AI summary. So the website is performing, and it showed up for some of my friends too, but they're all sort of in the same area. So I don't know. You can check and let me know if it works wherever you are as well. Hopefully it does. Um, the search terms gay somatic therapist NYC, that is harder. There's a lot more competition for that, but I have been showing up in that search, not as frequently, but I have been showing up in that search. Then there's the search somatic therapist NYC. Take out the gay. That's much more competitive. SeanHershey.com never shows up in that one. Somatic therapist NYC is Sean Hershey does not show up. Folks, guess who often shows up in that search? Somatic therapist NYC. One of my competitors in this search, who is doing better than me in the SEO game for sure, is the therapist with the EDS trifecta client with the pregnancy issues. And I'm like, okay. This bothers me because I'm like, here's someone doing somatic work who does not get neuroplastic recovery from chronic pain and symptoms, which is obviously not the only thing somatic therapy is for, obviously. Like that, there are so many psychological processes that live in the body and can be accessed and healed somatically. TMS is not the only problem in this world. There are many issues in this world. Okay. I trust that this therapist hopefully works effectively with other issues. But I just think that this is a big missing piece in this therapist practice. And I can sense the major lack of openness to it. I can just sense it. So here's the tea. I am like, I will outrank this individual someday. I'm like, you're going down, friend. I'm feeling aggressive today. I'm feeling aggressive because I'm like, people are dumb. And like I have been saying, I'm dumb too. So I'm not trying to like get too blamey, but I'm just like, people are dumb and you're going down. All right. I'm mad about this. I'm like, oh, like this person better be prepared to be in line behind Sean Hershey, LCSW, on the Google search page and the goddamn AI results page too, because I'm like, okay, I want us to get this mindset out there, right? Because people need to know. Like I said, what if you were encouraged, you listening to this, what if you were encouraged to think expansively about your health or about your limitations? What if you were encouraged to question your perceived physical limitations starting years ago? And I get that some people's physical limitations are permanent, are disabling. You know? Here I am struggling through reading this with my dyslexia. I don't think that's going anywhere. I'm struggling through reading these, like, long, difficult words. I don't think my dyslexia is going anywhere. Um, some people, we have limitations. Okay. Not all of your limitations are forever. What if you and I were encouraged to think expansively about healing our bodies, improving our health, working with and surpassing our limitations? What if you and I were encouraged to question this starting years ago? Well, we would both have less limitations today. Our lives would be bigger today. We would have avoided so much medical trauma that we have now been through today. We would have missed out on so much less of life, right? Right. But we're doing it now. We're doing it now. So we, you and me, we're making neuroplastic recoveries and TMS healing known. We're doing this. We are outranking these people who don't get it. We're doing it. And is neuroplastic healing backed by science? This is the whole point of the episode. Is neuroplastic healing backed by science? It sure is. It sure fucking is. All right. We are going to go out on some new royalty-free music from the royalty-free music library. I'm going to send you back out into the world on this lovely new music clip. This one I'd say it matches the vibe, because I'd say this one is giving like running through an open field. You're thinking expansively. You're thinking, I can do anything. My chronic symptoms are curable, and I have science on my side. Boom. Go run through that field. Go live your life. Your symptoms are curable. And I will see you next week. If you're looking for a therapist, you found one. And you can decide. Does my vibe resonate with you? Therapy is an opportunity. Therapy is an opportunity to tune into you, to learn to feel more comfortable being yourself, to feel more comfortable with your emotions, and to feel more comfortable existing in the world in your body. Do you have difficulties in your life? Maybe it's chronic pain, maybe it's something else. Maybe you want to become a person who likes yourself. Do you want a therapist to help you? And would you like me to get to know you and to help you? That is actually an option. You can find me at SeanHershey.com or MindBodyMedicineForChronicPain.com. Both go to the same place, and if you're looking for me, I'd welcome a message from you. SeanHershey.com, MindBodyMedicineForChronicPain.com, and you can request a free consultation.